But greetings from the Macon and Joan Brock Virginia Health Sciences at Old Dominion University and the Lawrence J. Goldrich Institute for Integrated Neuro-Health. This is one of a number of community outreach presentations that is focused on dementia, Alzheimer's disease, and topics we hope provide support and information to our patients, our families, and our colleagues. Today's presentation is Pioneering Approaches in Alzheimer's Treatment, Diagnosis, and Future Directions is being presented by Dr. Hamid Okhravi. Dr. Okhravi is the Alfred E. Abiouness Endowed Professor at the Glennan Center for Geriatrics and Gerontology, and he's the medical director for our Comprehensive Memory Center in the Goldrich Institute. He received his medical degree from Mashhad University of Medical Sciences in Iran, and he completed his internal medicine residency program at Hurley Medical Center in affiliation with Michigan State University College of Human Medicine. He completed a geriatrics fellowship for board certification as a geriatrician at the Mayo Clinic in Rochester, Minnesota. Dr. Okhravi was a successful physician in private practice and was appointed as community faculty for Abiouness in 2007. And we are very fortunate that he joined the Glennan Center as full-time faculty on July 1st, 2010. His efforts and those of his colleagues that include our clinicians and a host of clinical and research staff have brought us into the national spotlight as we are now members of the Alzheimer's Clinical Trial Consortium, or ACTC, and most recently, Dr. Okhravi was appointed to the board of directors for the National Alzheimer's Association. A friendly reminder, please remain on mute, and my thanks again for participating today. We appreciate you coming to join us and learn more about Alzheimer's dementia. Feel free to post questions on the chat. And so now I would like to please join me in welcoming Dr. Okhravi. Thank you.
Thank you very much, Dr. Castillo. And this is such a great pleasure to see you folks, of course, virtually. This is really an honor to be able to present. Let me see if I can share my slides. Please confirm that you can see my slides.
We can see you. Looks good.
Great, great, wonderful. Okay, well, here's the outline of my talk. I'm going to just be very quick because there's a lot to share and not enough time. I'm going to review the amyloid hypothesis first very quickly, and then jump on a quick review of original phase 3 clinical trials for lecanemab and donanemab in symptomatic stage of Alzheimer's disease. These are the medications that now are fully FDA approved. And then I will provide updates on new developments and results related to these two medications that have been available or presented since last year. And I'll talk about the major side effect of these medications by giving an example from one of our patients in our memory center. And then I'll move to the main part of my talk, which is the description and discussion about pivotal clinical trials in symptomatic stage, followed by discussion about pivotal clinical trials in preclinical stage. And then talk a little bit about near future of clinical trials. And finally, I'll touch base on the blood-based biomarkers, which is quite exciting. So here is the amyloid cascade hypothesis. There are quite a few different hypotheses in why or how Alzheimer's develop, but one of the most common ones is amyloid cascade hypothesis. And in amyloid cascade hypothesis, the main issue is revolves around, let me see if I can get a pen here as well. Okay. The main issue revolves around the amyloid plaque. So based on this hypothesis, for whatever reason, our brain is not able to clean up amyloid plaques from the brain, or the production of amyloid proteins increases. And for that reason, we will have these amyloid proteins that are very sticky they stick together, two of them become dimer, and then four of them become tetramer, and then finally they become oligomers, and then plaques, diffuse plaques and compact plaques. So the plaques are the first domino in this process. Now, for some reasons, when plaque formation happens, there is a cascade of events that will trigger formation of tau pathology. And tau tangles, those are another misfolded proteins that are quite toxic to our brain cells, and they will cause brain cell damage and brain cell loss. So then people develop memory issues, functional deficits, and then finally develop dementia. So based on this hypothesis, if we can block formation of plaques, and most probably we can block formation of tau or reduce the amount of tau formation in the brain, and then hopefully we can slow down this process of memory loss and dementia in the trajectory of Alzheimer's disease. Here are those two medications, the mechanism of action. What you see here, is actually a membrane of a brain cell. And within the membrane, there is a protein that is called APP, amyloid precursor protein. This is a big protein, as you can see here. And this protein will cleave, and that will produce the amyloid proteins. The first one is monomers here. And then, because again, they are sticky, they get together, they become dimer, and then tetramer, and then finally oligomer. They stick together, oligomers stick together, and then they become protofibril. And then finally, they become amyloid plaques. Lecanemab attacks the protofibrils, oligomers, and fibrils. Donanemab attacks mainly the amyloid plaques, and this is the way that they will reduce or remove amyloid, and we think this is why they slow down memory loss. Let's talk about lecanemab, and this would be a very quick review of the results of the phase 3 clinical trial for lecanemab. That was Clarity AD study. More than 1,700, almost 1,800 participants in this study with early stage Alzheimer's, meaning that very mild memory problem, meaning mild cognitive impairment or mild dementia. 18 months trial, that's the duration of the trial. Participants received either lecanemab every 2 weeks infusions versus placebo. The primary outcome was CDR sum of box, as you can see here, sum of boxes. And this is essentially a memory assessment and some functional assessment tool as well. Lecanemab got the FDA approval on the 6th of July in 2023. What you see here on the left-hand side, that's about the amyloid removal caused by lecanemab. And that's, again, we think how this medicine works. If you take a look, you can see the black line, that's placebo. The green line, that's lecanemab. Lecanemab was quite strong. By 1 year, 54% of people, more than half of people, became amyloid negative. By a year and a half, 2/3 of people became amyloid negative. So very strong medicine, but that's not enough. We really need to have clinical outcome. Here's about clinical outcome based on CDR sum of boxes that I said, which is a memory and functional test or assessment. There was 27% slowing in memory decline. As you can see, those two lines converge very nicely. That translates to 5.3 months of gain, time gain. Now, you may ask, what is that? What does that mean, 5.3 months? Well, this is how I explain to our patients. If someone is not on any medication within an 18-month period, and that person probably at 12 months will lose the ability of, let's say, driving or managing finances or taking care of medications or taking care of their calendars. These medications and lecanemab will keep that for additional 5.3 to 6 months within the 18 months period. And we believe that if people are on these medications for a longer period of time, the strength of or the impact of medication will be much higher. Now, What I showed was, of course, the results of the phase 3 clinical trial that led into approval of lecanemab by FDA. Now we have up to 36 months of results or data available. So essentially by 36 months or 3 years. What you see in this slide, the first part on the left-hand side, up to this line, the red line, that's the core study that I just showed the results before. And this is CDR sum of boxes, that memory test. And as you can see, and I kind of explained before, there was a 27% slowing memory decline. There's a divergence of those two lines, black being placebo and green being on lecanemab. Now, let's see what happened after that when the placebo group, black line, also went on medication up to 36 months. So you can see that these two lines are parallel. Now, this is one of the concepts related to disease-modifying agents, because we think that these are disease-modifying agents. For an agent to be disease-modifying, it means that if people are started on these medications, later on, by a delay, they will improve, but they will never catch up with the first group that they were started earlier. So that kind of suggests that these medications are disease-modifying. And again, this is the first time in the history of Alzheimer's disease that we've been able to show that. Now, of course, here, we don't have any placebo anymore because everyone in the open label extension is on medication from 18 months to 36 months is on medication. But then let's take a look at a group, a cohort that are very similar to this placebo group here. And what they did here, they took a group of people from a cohort called ADNI, Alzheimer's disease neuroimaging. This is an observational study. And they took people from that study. And as you can see, the ADNI cohort lied very, very nicely, transposed very nicely on the placebo group in the lecanemab study. So, and these are, and from ADNI, those people are also on no other medication. Now, let's follow those people from ADNI placebo up to 36 months. As you can see, the ADNI placebo diverges from those two lines that are on medication right now. And those lines become even a little bit wider. So this is not really the best way of comparing, because we like to have the same time, the same placebo group, but of course we couldn't. This is the best way that we can show. So it seems that people who are on medicine, they continue benefit from these medications, and the benefit may even get stronger. At least we have, again, right now, evidence up to 36 months. This is another study that they, of course, the same study, the lecanemab trial. They looked at people who have very low tau level in their brain. And people with low tau, they are at the very early stage of Alzheimer's. Essentially, their memory is also not really that bad. It's impaired, but at the beginning of the impairments section. They looked at people who had no decline, and they looked at people who had improvement, compared lecanemab with placebo. But you can see here, and this is a percentage, 76% of people on lecanemab had no decline versus 55% on placebo. 60% of people on lecanemab, they actually improve compared to 28% in placebo. So it seems that, and this is a kind of an indication that probably if you go earlier, we get better response. This is another exploratory analysis. They looked at measures of patient health quality and also caregiver burden. So there were 4 different tests. The first one on the left here, that's European quality of life. The second one is quality of life Alzheimer's disease that the participants filled out. And then quality of life for Alzheimer's that the proxy, the caregivers, filled out on behalf of participants. And then finally, we have a burden scale. Here's their burden interview. Red is patients who were on, participants who were on lecanemab. These are all blinded. They didn't know whether they're on medicine or not. That's actually the interesting part. As you can see, in all different measures of quality of life, and also burden. Quality of life was better in participants who were on lecanemab versus placebo, and caregivers had less burden for participants who were on placebo, were on lecanemab. So again, this is another indication that these medications not only help, with memory and functional status, but also they help, of course, as a result, they help with quality of life and decrease caregiver burden. Now, within the 18 months of study for lecanemab, we used to give the medicine every 2 weeks, and FDA also approval came with continuing with lecanemab for forever, every 2 weeks. But then there was a study that they looked at 48-month data, and they did some modeling, and they kind of compared giving lecanemab every 4 weeks versus every 2 weeks, starting after 18 months or 24 months. Now, and you can see in terms of amyloid plaque removal here, there is really not that much of difference between every 2 weeks versus every 4 weeks after 18 months. And also in terms of the CDR sum of boxes, the memory test and the functional test, there is really no difference in outcome. So for that reason, Eisai applied to get the FDA approval, and they did. They received the FDA approval for the modified dose in January, and now our patients who have been on lecanemab for a year and a half, now they are going to go on every 4 weeks rather than every 2 weeks. So this is another good step that we have gone through. Now, another exciting news is about subcutaneous lecanemab, because as you know, right now, lecanemab and donanemab, they are available in infusion form. So people need to go to infusion centers every 2 weeks or every month, depends on medicine, and receive the infusion. That's quite sometimes, I would say, burdensome. So now there is a study about subcutaneous lecanemab that is coming probably to end very soon. So based on initial analysis, the subcutaneous one, which is actually injections, right? These are subcutaneous shots that you give it yourself weekly. So there is 14% even greater amyloid plaque removal compared to the infusion administration. They also show lower systemic injection reactions, and there's really no systemic, I would say there's no local injection site reaction, except very mild to moderate one, which is about probably 8%, mainly redness, irritation, swelling. And there is really no generalized skin rash or hypersensitivity reactions. And there's similar incidence of ARIA that I'm going to kind of describe. ARIA is one of the main side effects of these medications. So FDA has accepted the application to review, and I'm really hoping within the next year or two, we will have the subcutaneous form available, and that makes really a difference. Let's talk about donanemab. So donanemab had a phase 3 clinical trial, more than 1,700 participants, again, early stage Alzheimer's disease, either mild cardiac impairment or mild dementia, 18-month study, and it was donanemab monthly infusion versus placebo. It got the FDA approval on the 2nd of July in 2024, last year. Here is about the removal of amyloid from the brain. Donanemab is stronger compared to lecanemab. So as you can see, by 24 weeks, by 6 months, 40% of people become amyloid negative. By less than a year, 70% become amyloid negative. By a year and a half, 80% of people become amyloid negative. Let's take a look at that CDR sum of boxes for the memory and functional scale. And as you can see here, now there's a 36% slowing in memory decline in the group that they had low tau level in the brain. So there is now here 6.3 months of benefit compared to 5.3 months related to lecanemab. They're very similar. It's not really that much of difference between these two medications. So again, this also got the FDA approval. I think we have now something around 50 to 60 people on these two medications. We started lecanemab as well several months ago. So now let's just talk about the side effects, the main side effect of these medications, which is amyloid-related imaging abnormalities, or ARIA. I'm going to explain one of our patients who developed ARIA when we started medicine. This is a Caucasian female, 77-year-old, who we started medication. We started actually lecanemab in June of last year, June 27 of last year. This is the first baseline MRI. This is before starting infusions. And by the way, these are like horizontal sequences looking from the top. And this is quite clean, no issues, no concerns. So the patient had her fourth infusion, and then before fifth infusion, we needed to do surveillance MRI, and we did, and that was on August 13. And the patient at that time complained of headache and nausea, and the patient happened to have ARIA, amyloid-related imaging abnormalities, edema, meaning like swelling, maybe a little bit of a fluid getting out of the brain vessels. And what you can see here, this is actually right temporal lobe. Right is left, left is right. That's the other way around. So this is right temporal lobe. We see ARIA E on right temporal lobe. That's again swelling, and also the left temporal lobe, right occipital lobe, right frontal lobe, and also left frontal lobe. So this was moderate ARIA. So we held the medicine. We repeated the MRI later on, and it actually, patient became asymptomatic, no symptoms a month after that. Here's just to show you another ARIA, which is ARIA H, or hemorrhage, or microhemorrhage. These are small areas of bleeding in the brain that the patient also developed. As you can see, those small areas, it's like kind of a dots. So those are amyloid-related imaging abnormalities, hemorrhage. And for this patient, because she had more than 10 new ARIA H, or small areas of bleeding, we had to permanently discontinue medication. Patient is asymptomatic, is doing fine, but unfortunately, we couldn't really continue with the medicine. Now, here's the comparison of donanemab and lecanemab for ARIA E. And the main risk factor for ARIA is a gene which is called ApoE4. There are different copies of ApoE. We have copy 2, 3, and 4. We get one copy from each of our parents. For example, I can be ApoE2, ApoE3, or ApoE3, ApoE4. ApoE4 copy is also a risk factor for Alzheimer's, but that's also a risk factor for ARIA. And if you have one copy, your risk goes up. If you have two copies, your risk goes significantly higher. And I'm going to show you that here. So here on the left-hand side, we have the ARIA E. And then in the middle column, we have the lecanemab group. And then right column, we have donanemab. If you take a look at non-carriers, people who have no ARIA, no ApoE4, for lecanemab, the risk of developing ARIA is 1 in 20 patients. For donanemab, that's 1 in 6. If people have one copy of ApoE4, for lecanemab, that's 1 in 10 patients. For donanemab is 1 in 4. If people have two copies, that risk goes up to 1 in 3 for lecanemab and almost 1 in 2 for donanemab. So that's the ApoE shows that how it increases the risk of ARIA E. Now, I want you also to draw your attention to infusion-related reaction, because these are, of course, infusion medications. They may have some reactions. For lecanemab, that's 1 in 4, mainly mild issues. And for donanemab, that's less, is 1 in 10. Now, there was a new study that did a very, very interesting thing here in terms of donanemab, to see if modified titration will help to decrease the incidence of ARIA E. Here, what you see on top is the standard dose that we give to patients. And as you can see, we give 2 vials, visit 1, visit 2, visit 3. Those are 1 month apart. And then after visit 3, we go to 4 vials. That's the standard way. In the modified way, what they did, they took just only 1 vial from visit 1. They added that to visit 3. So essentially, patients get 1 vial in visit 1, 2 vials in visit 2, 3 vials in visit 3, and then after that, 4 vials on. Let's take a look at the incidence of ARIA. Here on the left-hand side, I'm going to show you the homozygotes, as you can see there. If people were on standard dose, 57% of them developed ARIA-E versus 19% if they were on modified dose. So essentially the risk became a third. So 2/3 decrease in risk. That's quite significant. If they had one copy of ApoE4, so essentially homozygote like two copies of ApoE4, and heterozygote is one copy of ApoE4, the risk decreased from 23% to 14%. If they didn't have any copy, the risk decreased from 15 to 12%. And on the right-hand side, that's about symptomatic ARIA, and you can see the risk decreased significantly when they were on modified dose. So now, since October of last year that this was presented in a conference, we've been offering this modified dose as well to our patients. So now let's talk about current clinical trials in symptomatic stage, early stage Alzheimer's disease. Before I review the first one, I just wanted to share with you about blood-brain barrier. So here's the brain tissue. Here's a blood cell vessel, as you see here. There is tight junctions between those blood vessel cells, and that makes it very difficult for material to come from blood to go to the brain. And that's for a good reason for our brain health, because this will prevent toxins or bacteria or viruses to go to our brain. But by the same token, they also prevent 99% of anti-amyloid medications from entering the brain. So essentially with lecanemab and donanemab, only 1% of medicine goes to the brain. So the question is, if we can increase, is there any way that we can increase the concentration of these medications in the brain in a way? And the answer is yes. This is a very interesting study called Brain Shuttle AD. The name of the medicine is trontinemab. So what you see here on the left-hand side, that's a blood vessel. In the middle, that's the blood-brain barrier. On the right-hand side, that's brain tissue. So now with this mechanism, with this trontinemab or brain shuttle, we try to bring more medication to the brain, increasing the concentration from 1% to whatever we can. So this brain shuttle or AD or trontinemab, that's the name of the medicine, has two components. It has one component, which is an anti-amyloid antibody, as you can see here. And then this is a brain shuttle. And this is such an appropriate name. So this brain shuttle has a high affinity to bind to that receptor, which is on the endothelial cell of blood-brain barrier. So this shuttle binds to that receptor, and that receptor takes the shuttle and also the medicine, the anti-amyloid antibody, inside the brain tissue. Essentially, we fool this blood-brain barrier. So with this mechanism, we can increase the concentration of the medicine by 8-fold. So now let's take a look at how effective this is in removing amyloid. On the left-hand side, you see it in the graph, it's actually showing you by 28 weeks how strong and how fast this medicine can reduce the amount of amyloid plaques in the brain. This is the kind of threshold of negativity underneath. So this is very, very strong medicine. And if you take a look at it on the right-hand side, by week 28, which is 6 months or so, 75% of people become amyloid negative. Now, if you take a look at that number for donanemab, that was 40%. So this is much, much stronger. And by the way, this brain shuttle AD also shows that it decreases the incidence of ARIA as well, the side effect of these medications, so which is great for patients. So this is right now in phase 2 clinical trial, and hopefully this would be something that we can use with different medications. Now, you've all heard about Ozempic, right? Ozempic is good for diabetes, for cardiovascular issues, of course, for obesity, lots of prescriptions given. But it seems that, and Ozempic is actually a medicine called GLP-1 receptor agonist or glucagon-like peptide receptor agonist. So it seems that GLP-1 has also some positive effects on brain. So essentially that decreases the oxidative stress, and neurotoxicity. And also it acts on beta amyloid and tau protein and quite a few different advantages. Now, there was a big study that they looked at 3 clinical trials using either liraglutide, which is again GLP-1 analog, or semaglutide, either subcutaneously, the shots, or orally. So 16,000 people, these people are all having diabetes mellitus, and they followed them for 4.5 years. What they found that there was a 53% reduction in the risk of developing Alzheimer's in people who were on these medications compared to placebo. So then because of that, there are 2 now clinical trials called EVOKE and EVOKE Plus. These are phase 3 clinical trials, more than 3,700 participants in these 2 studies. The age is between 55 to 85. Again, the intervention is semaglutide or Ozempic oral versus placebo. These are similar studies. The only difference is that for EVOKE Plus, we include much more of people who have vascular culprits in their brain as well. This is a 2-year study. Primary outcome is the same as we had for lecanemab and donanemab. And the primary readout is this year, the 2nd quarter. So, by few months from now, we may have another medicine. If the result is positive, we may have another medicine that we can offer our patients. So this is quite exciting. Now, let's talk about prevention clinical trials. But before that, I want to just kind of show you what happens to our brain volume and size when we go through the spectrum of Alzheimer's disease. Here's the volumetric studies, MRI volumetric studies in one of our patients who had subjective memory complaint and then later on happened to have Alzheimer's. These are people, subjective memory complaint. They complain of memory loss, but when we do the memory test, everything is fine. What I want you to do is that, first of all, there are 100 different areas in the brain, left, right, and in these different areas, we compare the volume or size to other people the same age. I want you to concentrate on the red area here. So I want you to follow the red band. So red band means atrophy, means shrinkage. So you see just only one area in the patient with subjective memory complaint. But let's just kind of move forward a little bit in the spectrum with mild cognitive impairment. Now people have much more memory loss that we can find in our memory test. This is a patient with mild cognitive impairment. As you can see, those red areas or red bands are much more. Now, let's kind of move on into the spectrum and trajectory. Take a look at a patient with dementia, mild dementia. You can see that there are much more of those red bands. So this patient has much more of shrinkage and atrophy in the brain. So maybe really attacking the disease at this stage, maybe it's a little late. Still, it's promising, it's good, but maybe we can kind of switch the clock back, maybe kind of set the clock back a little bit more. Right now, here's the area, the dementia that we act, and usually at the dementia stage, as I showed, there's a 36% reduction or slowing down in memory loss. If you go to mild cognitive impairment, that probably becomes about 46% reduction. So now, if you go to preclinical, maybe that's the area that we can probably get closer to 100%. The closer, the better. So I'm going to talk to you about 3 different studies. One of them is AHEAD study, which is lecanemab prevention clinical trial. This is a randomized clinical trial, ages between 55 to 80, funded by NIH and also ESI and other philanthropic organization. There are 100 sites, 75 or 79 of them in North America, and EVMS is one of the sites. We had actually 21 patients randomized, and I think now we have 18 or 19. We had the highest number of African-American participants in the entire nation. We started the study, actually the study started in August of 2020. We joined the study in, I think, October of 2021. The randomization finished October of last year, and the readout for this study would be October of 2028. It's two different studies. A3 study, which is a phase 2 clinical trial, close to 450 participants. And these are people who have amyloid plaques in the brain, but the amyloid plaques in the brain in some of those people may not be even to the point that we call it positive. So this is the first ever trial aimed at stopping the earliest signs of Alzheimer's disease. And participants receive lecanemab every 4 weeks for 4 years. And the primary outcome is here biomarker, because these people are so early in their trajectory, probably 4 years is not enough for them to develop any significant memory issues. The next one is AHEAD 4-5, which is part of, again, the AHEAD study. And these are close to 1,200 participants, phase 3 clinical trial. And these people have positive amyloid plaques in the brain, and they receive lecanemab every 2 weeks for 2 years. And then after that, every 4 years, every 4 weeks for the remainder of the study, which is additional 2 years. And the primary outcome is cognitive measures. I just wanted to share with you that how extensive these studies are. To have about 1,500 participants, more than 20,000 people were screened. In fact, in our center, we screened close to 300 participants for this study. Another prevention clinical trial is about donanemab, and that's Trailblazer-ALZ 3. This is again phase 3 and started August of 2021. Enrollment finished August of last year. And the objective is to see if donanemab can prevent or delay clinical progression to Alzheimer's dementia in preclinical Alzheimer's disease. Participants are 2,200 people, aged between 65 to 80. It's interesting, in this study, we didn't do amyloid PET imaging or CSF analysis to confirm Alzheimer's, just only with the plasma biomarker that I'm going to talk to you later on, how good this test is. So the primary outcome is, again, time to clinical progression to either mild cognitive impairment or dementia. Locations are over 200 sites. Now, in this study, we're going to give only donanemab 9 months, 9 shots. That's it. And then the rest would be observation. And probably look and see if just only 9 shots will be enough to prevent or slow down memory loss in people at the preclinical stage. The readout for this study would be November of 2027. So again, tune in. For this study, more than 63,000 people were screened. The last one for prevention clinical trials is Trail Runner. Remember that the other one was Trailblazer. This is Trail Runner. And this is about remternetug. And remternetug is the cousin medicine of donanemab, the same, but it's much more stronger. So as you can see here, with a dose of 2,800 milligram, here in actually blue, at 85 days, it reduces the amount of amyloid plaques in the brain from 100 to less than 10 centiloid, and that's quite strong. So this study, again, between ages of 55 to 80, here also very similar to Trailblazer, only p-tau was checked, no PET scan, no spinal tap. And these people are people who are people who have very mild memory problem or no memory problem whatsoever. This is kind of the way that this study works. When people get randomized, as you can see here in blue, this is a subcutaneous medicine, again, a shot. So people go on either subcutaneous remternetug versus placebo, and then by 18 months, they stop, and then they just only observe and do memory tests every 26 weeks up to this point. And then after that, people who are on placebo can go on remternetug as well. The primary outcome is, again, time to progression on the test, CDR sum of boxes, CDR global score, I'm sorry. And we will be at site just in a few weeks from now. Now, nothing is better than prevention compared to treatment, and nothing is better than vaccination. So there are some safe vaccines, relatively safe vaccines are going on. The reason that I'm saying safe vaccines, because when I was in my fellowship, I was involved with the first human trial of active vaccination with a compound that is called 1972. And we had 6 patients from Mayo Clinic, total of over 300 participants in the study. That was a global study, but unfortunately 18 people developed autoimmune encephalitis, and some of those people died, and that study halted prematurely. But now these 3rd and 4th generation vaccines are safe, much safer. As you can see here, there are quite a few of them here, 4 of them, 2 of them against amyloid, the first one and the third one. One of them is against tau. And then another one, the last one, is against amyloid and tau. It's a dual. And if you take a look at the age, is between 40 to 65, primary prevention. This is quite actually interesting. And these are people who are at high risk of developing Alzheimer's because of, for example, genetic predisposition. But there are also 2 additional studies that they are in phase 2 clinical trial, and those are also very promising. So hopefully the result will be available soon for the phase 2 clinical trials. So where do we go from here? Well, we talked about moving earlier in the trajectory, but another thing which is important is combination therapy. Why? Because if you take a look at Alzheimer's disease, there are different culprits. It's not just only amyloid. It's good to go before or after amyloid, but also other culprits are important, like tau, or inflammation, or oxidative exposure, or other types of mechanisms that are involved. So for that reason, combination therapy makes really more sense. The other thing is that when we get older, it's not just only about Alzheimer's, that is amyloid and tau. People may develop other proteinopathies, we call it, or misfolded proteins in the brain, for example, alpha-synuclein or TDP-43, and they become also quite important. And for that reason, probably it's good to go after other misfolded proteins as well. Now, this is becoming a reality probably in a few months from now. The Alzheimer's Clinical Trial Consortium that we, as Dr. Castillo mentioned, we are a member of, is working on this tau platform. So as you can see, there are 6 different arms for this study, and 2 of them are a combination of anti-amyloid and anti-tau medication. The anti-amyloid is lecanemab here. So this study will be available, and we will be a site for this study later on this year. Let's talk a little bit about blood-based biomarkers. Can they be used as standalone confirmatory tests that we don't really need to do additional tests, for example, amyloid PET imaging or spinal tap? Here's about plasma p-tau 217. And what you see here is something called area under the curve. And the AUC, when it's 1, that means that test is perfect. And by the way, we don't really have such a test to be perfect, meaning that 100% of time, if this test is positive, then the patient has that condition. Or if 100% of time, if the test is negative, the patient doesn't have that condition. But the closer the AUC to 1, the more accurate the test is. And over 0.9, 0.85, 0.9, that's quite darn good. Let's take a look at this plasma p-tau 217 for differentiating between Alzheimer's and other types of dementia. This is the area under the curve for p-tau 217 plasma, p-tau 217. As you can see, it's quite actually good, pretty good. And AUC is 0.96. Now, if you take a look at spinal tap, the plasma p-tau 217 in CSF, that only adds this part of the surface. So if you compare with the CSF, this is pretty good. Right now, there are 7 plasma tests available that are commercially available. In fact, in our memory center, we've been using that for the past 18 months, 24 months in selected patients. And we use the last one here. This is the most accurate one among all of those 7 ones. But now, of course, this is available. We don't really recommend, for example, primary care physicians to use it or other specialists unless this is something that you're very familiar with and you know what to do with the outcome of that test. In this study, they looked at the accuracy of blood tests standalone versus specialists like me, dementia specialists versus primary care physicians. So what they did, they gave all the information to specialists and primary care physicians, for example, the CT of head, the memory test results. They gave also the patients so they could examine the patient, get all the information. So they came up with their own diagnosis. For specialists, only 73% of time they were accurate, 27% wrong. If you take a look at primary care physicians, 61% accurate, and the rest actually they were wrong. So 39% wrong. If you take a look at just this test standalone, 91% accuracy. This is how good this test is. It's a bittersweet because, of course, did better than us, but it's just amazing how good this test is. It's like kind of too good to be true, but this is really true. And right now, Alzheimer's Association has a group of experts to look at, to develop guidelines for memory clinic specialists to see if we can use these tests standalone. And that the guideline will come up probably in a few months from now. The last thing that I'm going to share, which is also interesting, is about, okay, now we have this plasma biomarker, which is very accurate, but is it possible that you can do it at the comfort of your home rather than going to the lab? Essentially, the lab sends you a kit, and then you put a drop, like what you do for diabetes. You put a drop on the kit, as you can see here, and then send it to the lab, and then they can come up with the diagnosis whether this is Alzheimer's, you have Alzheimer's or not. And here is kind of showing you the results. This is in the middle. This is the the drop, the capillary drop, and then on the right-hand side, that's plasma. And if you can take a look at AUC compared to CSF, the AUC for the drop is 0.88. The AUC for plasma is 0.98. Of course, this is less than plasma, but still pretty comparable with plasma. So that's another thing that probably may be possible later on, that we will have this test available. So I'm going to stop there. Here's, of course, our Glennan Center group, our Neuro-Health Institute group, and also our research group for our ugly Christmas sweater contest. And here is our research team that have been really working with us tirelessly on different studies that we've had. I can't really tell you how happy I am about what they do. And here is kind of for clinical research opportunities, our website, and also research link. Feel free to use the QR code or also go to our website. I'll be more than happy to answer any questions.
Thank you, Dr. Okhravi. Just amazing. I remember in medical school, it was only about plaques and tangles. That was what Alzheimer's was about, and it's so much more. There are a few questions. We have one. What is the criteria for starting these medications? Are they stage related?
Yes, very good question. So let me just see if I can discard and I can see people around. Okay, yes. So these medications, there is a kind of window of opportunities for these medications. These are mainly for people with mild cognitive impairment or mild dementia. There's some criteria based on the memory test. There are some criteria based on functional status. So yes, there is criteria. So there is a window of opportunity. For that reason, it's so important. The early detection is so important to be able to help our patients.
Thank you, Dr. Okhravi. One other question, and again, if anyone has questions, please put them in the chat and we will address them there. What is being done to educate community PCPs and neurologists about current practices and appropriate referral to your memory care center, etc., in order for patients to know early enough in the disease process to take the medications that will help?
This is really an unmet need. And I think we got kind of a little bit by surprises having these two medications now FDA approved. I don't think, and I totally agree with the question that you brought up. I assume that we all agree that we're not ready. We really are not ready because, for example, for us, it took us more than a year to really develop our system. And by the way, this is what we do day in and day out. We've been doing that in our research for the past, 4 years or 5 years. So we're very familiar with that. So I agree that the PCPs, even general neurologists, general geriatricians, they're not ready. And you can imagine in our area, we have, just in our region, we have, I think, more than 40,000 people with Alzheimer's disease. And we have now 60 people on these medications. They're probably one of the 3 centers that provide this medication. So probably total number of people who are, on these medications in our area is not more than 100 people. So it's not enough. We definitely need to work on education. And I know that Alzheimer's Association, they have initiated some initiatives, some work. And also here at Neuro-Health Institute, that's something that we will provide hopefully soon. We're working right now with our development office and also our department to hopefully have some maybe workshops or educational sessions for primary care physicians, but more importantly, for neurologists, for geriatricians, for geriatric psychiatrists, to be able to really bring them on board for using or prescribing these medications.
There's one other question. I think we have a few more minutes. Where do people in this area actually get these medications?
Well, again, we have been providing that since probably more than actually 18 months ago. We started when lecanemab got the FDA approval. So we see patients here in our office, but there are a couple of other practices here also. I think they do provide these medications. They started recently. I think one of them is Centero. So they do provide that as well.
Thank you, Dr. Okhravi. I don't see any other questions. Again, we have a couple more minutes. Oh, sorry, here's one. Let's see, sorry. Are you seeing interruptions to your research due to current governmental cuts on research, even specifically related to Alzheimer's dementia? Also, when or how should family members look into being concerned about looking into preventative medications? So 2 parts to that question, Dr.
I think the second part is much easier, so I'm going to answer first the second part. So, and I assume this is about caregivers themselves rather than patients. Am I correct? Can you, that you posed the question, can you verify that? This is about caregivers or family members rather than patients, because you're talking about prevention. And you can unmute probably and talk.
Saying family members of those who are diagnosed, so the
Okay.
caregivers.
The caregivers. So here's what I would say. First of all, if you notice some change in your memory, these are red flags for getting really checked. And what are those red flags? Age over 60, having family members with dementia or Alzheimer's, having genetic predispositions. Nowadays, people can do whatever, 23andMe and other stuff, and you can have your risk. Or if your loved one is also concerned about your memory loss, that's very important. Or if you have subjective memory complaint and that really lasts beyond, let's say, a few months or so, because, when we have surgery or when we have a really catastrophic event, it may affect our memory, but then we catch up, we get better. So if those things happen, I think it's a great idea to have it checked, because the earlier the better. Now, the other thing is, as I mentioned, prevention clinical trials. Nowadays, we have prevention clinical trials, and that would be probably a best way of participating in these clinical trials. That would be another opportunity for people who are really interested and they have some family history. One more thing, if you have multiple cardiovascular risk factors, for example, blood pressure, cholesterol, diabetes, smoking, that also puts you at much higher risk. So that will be something else to kind of consider. If you notice some changes, then you probably need to get checked.
Are you able to comment on the first part of that question, Dr. Okhravi?
I was thinking that I can probably get away. So anyway, we don't know yet, but this is my impression. Well, as you know, when we have funding for research studies, there is an indirect cost as well, and an indirect cost covers the overhead, and it's usually about 50%, and some institutions up to 80% overhead. Ours, I think that was something around like 40 to 50%. Now that has been cut to 15%. And I'm not quite sure institutions, if they can really afford to have these studies, because probably they can't even cover the overhead. That's a big concern that I have. So we don't know how this is going to unfold, because there are as you know, there are lots of discussions, even lawsuits going on, and we really have to wait and see what's going to happen. Am I concerned? Absolutely, I'm very concerned. But the thing is that at least the good news is that it's not going to affect our clinical practice. But from the research standpoint, I am concerned.
Thank you, Dr. Okhravi. And I think this may be our last question as we're coming up on the hour. Can these medications be taken if you're on blood thinners?
Well, it depends on different practices. If you take a look at the lecanemab study, 5% of people were on blood thinners. But then after that, we have appropriate use recommendations written by experts in the field. Based on appropriate use recommendations, they don't recommend starting people on blood thinners on these medications because of increased risk of bleeding. And we follow that recommendations. Most practices follow that recommendations, but there are some sites in the nation that I know they give these medications. Now, this is right now because we don't really know that much about these medications. Later on, maybe, a year or two from now, that we have much more information about these medications, that may be possible. But right now, at least in our center, we do not really give to those people who are on blood thinners.
Thank you, Dr. Okhravi. We're down, it's almost 6 o'clock. Dr. Okhravi, amazing lecture as always. Very, very, very informative. And it's not only Dr. Okhravi, but we have a whole team that helped bring this together. David Elkins from the research team and the research team in general. I saw a few on here as well. And Ms. Madeline Dunstan, who is our gerontologist, who is always such a key person when pulling anything education together. Dr. Okhravi, I'm sorry, and also our audiovisual team as well. We always thank you for making sure everything goes smoothly. And Dr. Okhravi, was there anything else as we end the session that you'd like to share with the audience?
I just wanted to say that please feel free to go online and really look at our website. We have a few studies, especially we have a registry that just follow people longitudinally, do memory tests and some blood tests and so on and so forth. So that will be some opportunities for people. If you haven't been part of our registry already, please feel free to take a look, and we'll be more than happy to have you on. And then there are other studies that they come when you're part of our registry. We definitely let you know that you may be eligible for those studies, and then you can probably participate.